my pleasure to introduce our speaker today. Joining us, we have Alexandra Kushliak, an educational consultant for advanced care planning, goals of care for the Calgary region of Alberta Health Services. Alexandra holds a Bachelor of Arts degree and a Bachelor of Social Work degree, and she is a registered social worker. We're so glad to have her joining us this afternoon. So Alexandra, I will turn it over to you, and I will stop sharing my screen so that you can start sharing your screen. Oh, you're on mute.
Sorry, folks. I'm so excited to be here with you, especially today. I'm not sure if everybody realizes, but today is actually April 16th is National Advanced Care Planning Day. So this presentation being on today was so apropos and so perfect. So this is our course. I just like to say I'm an educator with Alberta Health Services, and all I do all day long is educate staff within Alberta Health Services and outside of Alberta Health Services. And just so that you know where I come from, I've been a social worker for over 35 years. And during that time, I've worked in acute care, I've worked in the medical field, and I've worked with people around advanced care planning, around those personal directives and goals of care. So my experience comes from working out in the field. But on top of that, also I'm an individual person and I have the personal experience. My mother is in long-term care. She has a personal directive and I'm agent of that personal directive. And of course, I have my own personal directive. So that's just a little background. I'd like to thank you all. It's so wonderful to see so many people attending today, especially when it's Advanced Care Planning Day. So I know we're all a bit stressed with COVID. It seems like we've been a whole year under stress. I put there on my little friend, the mouse up, just to let you know that included in the notice is all kinds of written material around the personal directive, around advanced care planning. So you don't need to take notes. You don't need to memorize through the presentation because it's all presented to you in a couple of the publications. So unfortunately, this is what we've been seeing, and I so hope that by now we wouldn't be seeing this image anymore, but we're still seeing it. And what comes to people's mind is saying, you know, the world has changed so much. How has advanced care planning, goals of care, and the personal directive changed? Well, it hasn't changed at all. We still have the same policies. We're still following along in terms of the goals of care, what people want. But the thing that has changed is our everyday lives. We're able to see now what ICU looks like. And most of all, that's worst thing that's happened is that if we end up in hospital, unfortunately, our loved ones can't always be there with us. And sometimes people are alone in hospital. So what we do want to do with COVID is to prepare. We want to make sure that if we land up in hospital, that we know that our healthcare providers, our families know what kind of healthcare that we want. So I cannot talk about COVID, and I do want to make sure that you all know your risk factors so that if you're in that risky group that you know to take the extra precaution, especially now with the variants. You know, sometimes we think, oh, I'm healthy, I don't have anything, I'm not in that risky group. But that second one, older than 60, it hit me between on the forehead in terms of saying that's me, right? So sometimes any of us can have one of these risk factors. So I just want to make sure that you're aware of the numbers in Alberta. Unfortunately, we've got 416 people in hospital. There's 86 in ICU. We have, you know, we've hit the $16,000 mark for people being active cases. Unfortunately, our deaths have gone up to 2,034. When I first started doing this presentation last year, our average age of death was 84. So for it to go down in those numbers means that we have younger people dying now. And when you talk to the physicians now, we have younger people that are in hospital, younger people that are landing up in the ICU. The good news is that we have the vaccine. I was so happy to be able to get my vaccine. My mother, who's 91, got her vaccine. She's actually got the double dose. So there is sort of a light ahead, and I really want to encourage people to make sure that you get the vaccine when it becomes your turn, because it shows the cases in long-term care have dropped almost to zero. So it's really important that we get that vaccine, and it's even more important if you're in that risk group, right? So remember the other slide, same look at it in terms of over the age of 60, if you're carrying extra weight, if you have all kinds of chronic problems. So what I'm going to go through today is, in lieu of COVID, what can we do? What can we do to prepare? And the best way we can prepare is to have an advanced care plan. And we need to know what that is. We need to know how to do it. What is that personal directive? So I'm going to go through that step by step. I'm also going to tell you about what the goals of care are and how it's used in our healthcare system and what the green sleeve is, because those sometimes are all mysteries to people. So I'm going to start with this short video. This is Dr. Charlie Cork. He comes from Australia, and this video actually comes from Australia, but it really tells us what advanced care planning is and why it's so important. And I just like the way that Dr. Cork does it. If you're interested, if you Google him, he's got lots of videos on YouTube talking about advanced care planning. Oh, just before I start, I'm just going to make sure that my sound is good.
About 80% of people at the end of their life are in a position where they can't make their own decisions. I'm Associate Professor Charlie Cork, and I'm a specialist in intensive care medicine. Some people will say that my family know what to do, or my doctor will know what to do, and unfortunately they're wrong. When a family's got an advanced care plan and knows what their relative wants, it's enormously easier for the family, because they haven't got all the responsibility of making these, what they see as impossible decisions. And it makes it ever so much easier for the doctors, because doctors are trying to do the right thing. They just need to know what it is. I think advanced care planning, in a nutshell, is three important things. It's about thinking about it, and just thinking about it starts the process happening. Talking about it to your family, talking about it to your doctor. The third thing is picking a great decision maker, because 80% of us, right at the end, will not be able to make our decisions. Just at the end of life, the way the process goes, you're not able to make decisions, and decisions need to be made. And a great decision maker is able to talk to the family, talk to the doctors, make a decision, make the right decision for you, and to feel comfortable about it. And it makes the whole process so straightforward, so controlled, and so sensible. And that's really, really good.
So that was Charlie Cork. So what is advanced care planning? Well, like Charlie said, it's thinking about and sharing your wishes for healthcare with people close to you. So have you talked to people around you, your family members? Have you sat around the dinner table and talked about what your wishes are for healthcare, especially with COVID being in the picture? Have you chosen someone to make healthcare decisions for you? And in the province of Alberta, that person that we choose is called your agent. And where we write all this down is called the personal directive. And that's where it makes it legal. We're really lucky in Alberta because we have a Personal Directive Act, which also it outlines the legalities around the personal directive, how we do it, how it's legal, and who has to ask about it and how we act around it. You may be wondering at the bottom of my slide, I have those little people down there. And we're in a real trouble in terms of Alberta because only 2 out of 10 people actually know what advanced care planning is. So that's why we're so excited today that you've joined us. In Canada, our stats aren't any better. Most of us think that is, in fact, more than most of us, 93% of us think it's really important to talk about this with our family and friends, but only 36% of us do it. 80% think it's really important to discuss it with a healthcare provider, but this stat is even worse. Only 8% do. think it's important to discuss it with a lawyer, but only 7% of us have. So those stats aren't great. So if we don't know what your wishes are, it becomes really difficult. So I'm wondering why our stats are so low. It's probably has something to do with this chart. And my father was one of those people saying, you know, why do I need a personal directive? Why do I need to talk about anything about healthcare? Because I'll just die and that's it. What kind of decisions are going to be made? Well, if he died in the 1940s or 50s, he probably would have been right, because we didn't have all the fancy things we do now. We don't have the great medications, the great things that we can do in an intensive care unit. And most people suffered from sudden death. They were maybe only sick for a couple of weeks before they died. So I always think of my husband's grandparents. You know, I'm a Ukrainian. It's a tradition to visit the grave sites, and I never did the math. But when I did the math, I found out, you know, they died quite early in their 60s. And a lot of it was because we didn't have the medications and we didn't have all the bells and whistles that we have now. So unfortunately, or fortunately, depending on how you're looking at it, we will all die in one of these three ways, whether it's terminal illness, whether it's organ failure, or whether it's frailty. And when you look at that, it's all over time, even a terminal illness. We have lots of people now with cancer who actually are considered that they have chronic issues in terms of with cancer, that they don't die right away, that it's over time. So, and over time, there's all these decisions to be made. I used to work in long-term care, and 85% of the people in long-term care don't have capacity in terms of they can't tell us what they want. And a lot of people are living in long-term care for 10 years. So can you imagine if your mom or dad or grandmother or grandfather were in long-term care, didn't tell you how kind of health care you wanted, didn't tell us who would be making those decisions for them, and somebody had to do that over a 10-year period of time. So that's why it's so important that we talk to our family and that we do those documents. Alberta Health Services teaches that there's 5 steps to advanced care planning, and they're quite easy. Number 1 is thinking about your wishes and values. So what's important to you? What makes you you? I always say that the personal directive is the only document that talks about you as a person. Number 2 is learn about your own health. I know that when I worked in hospitals, that there would be huge charts on people telling what was wrong with them. But when I talked to people, they didn't really understand. So if we don't know where our health is going to be in a month from now, a year from now, how can we plan? I work with Dr. Jessica Simon, who's a palliative care physician, and she always says, if this was your last Christmas, how would it be different than if you didn't know it was your last Christmas? So if knowing your own health and knowing what's ahead of you is going to make your plans a little bit different. Number 3 is choose someone to make decisions and speak on your behalf. I always have that 80-year-old lady who thinks it's a great idea to choose her husband to make decisions for her if she could not. But, you know, if her husband's 90 and is having his health issues himself, how is he going to make decisions for her? So it's really important that we think about who's that right person to make decisions for us. Do they know us? Are they going to be around? Are they going to be able, can we communicate with them? In Alberta, we're really lucky that we can choose an agent that doesn't live in Alberta, that doesn't live in Calgary, that doesn't live in Canada. As long as we can contact them by phone, they can be your agent. And especially now when we're Zooming and Skyping, we may be Zooming with someone on a regular basis and telling them about our healthcare condition, and they may live halfway across the world. So it's really important that you think about who you're choosing to make decisions for you when you cannot. Number 4 is communicate your wishes and values about healthcare. Remember that stat? We're thinking about it, but if we don't tell our families, if we don't tell our healthcare providers, then it's kind of like you haven't told anybody. And then when something happens, we're not going to know. The 5th is where we make it legal, is that document in a personal directive. And remember I said we have a Personal Directive Act that makes it legal, that has all kinds of rules and regulations around it, so that ensures that your wishes are going to be followed. So advanced care planning is that process, that think, learn, choose, and communicate. And where we do it is called the personal directive. So I talked about a personal directive, and I talked about a little bit about my dad, and he was the one who was saying, oh, I have a will and I don't need anything else. But a personal directive is not a will, and it's not enduring power of attorney. In fact, in the province of Alberta, we need all three documents. So a will doesn't get looked at until after you die. An enduring power of attorney is for someone to manage your money and estate while you're still alive. So again, nothing to do with healthcare. So the personal directive is the only document where you name someone to make decisions around personal things and around your healthcare decisions. So very important. So that's why I want to make sure that you understand that the personal directive is a legal document. It's where you appoint your agent, and it's where you write down your healthcare wishes and instructions. So your personal directive doesn't come into play unless you lose capacity. So some people say, you know, I don't want to do that personal directive and then somebody's going to take over for me. That's not how it works. So when you lose capacity, the physician needs to fill out specific documentation along with someone you've named in your personal directive. So there's a process there. I have a personal directive. I'm still making my own decisions, and it won't come into play until I lose capacity. My mother, on the other hand, she has a personal directive. It was enacted by two physicians, and I am now making decisions with her, for her and with her. So you can write a personal directive without a lawyer, so it doesn't really have to cost you a lot of money. You are to keep the original in a safe place, but we really want you to share that personal directive. Make sure you give copies to your agent, your healthcare providers, your family, because if we can't find it, and if we don't know you have it, it's kind of like you didn't do it. So if you've gone to a lawyer and gone to all that trouble to do it, and then we can't find it, it's kind of a waste of time and money. Or if you've done one yourself, but put it in a safety deposit box and we can't find it, then again, your personal directive should not be a secret. Your family should know about it. Your healthcare providers should know about it. And your agent should know where your original is. So Personal Directive Act has made it really easy for us to do a personal directive. There is no standard form. As long as it's signed, dated, and witnessed, it's considered a legal document. One of the pieces of information that we've supplied is the template from the Office of the Public Guardian, but Dying with Dignity also has their own template. Either one of those is great, and you can use that. As long as it's signed, dated, and witnessed, it becomes a legal document. If you have a personal directive, check your documents, because in that documents, sometimes we do wills at the same time we do a personal directive and enduring power of attorney. The lawyer will have a sort of a 3-for deal, and we don't realize there's other documents in there. So at this time, I think if Nicole can put up the poll, just want to see how many people out there already have a personal directive.
Okay, I'm going to launch the poll now.
And it's okay if you don't know. And just a reminder, we can't see who's voted. The voting is anonymous, so don't be afraid to vote. So once you've voted, just click the button that says submit.
Okay, let me know when you want me to share the results.
I think we're almost there, so you could probably, yep, so nope, there's a few more people voting. Yeah, I think you could share the results.
All right, here we go.
So great news. The majority of you have a personal directive, and some of you don't, and some of you aren't sure. So for those people that aren't sure, make sure you check your documents. And for people that have a personal directive, I want to encourage you to have a look at that personal directive, because I'm going to go through a personal directive now to sort of show you in terms of some of the things that you can put in there. So that would really help you in terms of being able to go through your personal directive and to make sure that it says what you want it to say. So the first thing about a personal directive is that it's not like a will, in terms of you can have more than one personal directive in play at the same time. And I've been in that situation where I had a client that they had two personal directives. They were both enacted with two different agents. So if you don't revoke any of your previous personal directives, you can have more than one. So if you're going to make a new personal directive, make sure you revoke all your previous personal directives. Designating an agent, as I said before, it's really important how we do it. Writing our healthcare wishes and instructions and our witnessing is important. So I talked a little bit about how you choose an agent, but how do you write it down in the personal directive? It doesn't matter how we write it down. Well, it certainly does. So in the first option, I have Mary and Bob, and it goes down the line. And remember my 80-year-old lady? Well, she's always the one that's got 5 children, says, you know what? I don't want to offend any of my children. I'm going to name all 5 of them, because then there won't be any fighting. But unfortunately, if she does that and names all 5 with and in between, that means they have to together come up with a decision. And sometimes in families, that's not that easy with that many people. The Personal Directive Act does allow for them to choose a spokesperson, and majority does rule. But it can be problematic for some families. I know for my family, that many people trying to make a decision would never fly. They'd have 10,000 different opinions with 5 people. The next option is you can put Mary or Bob, which would mean that Mary could make decisions. And if she went out of town, then Bob would be able to make decisions, and they could switch out. Again, these 2 people have to work well together, because it would make it really difficult if they kept on changing the way that things were going. So it's really important that you think about what works for your family. If you've got family members that work well together and one goes out of town and you want to share the responsibility, that might be a way to go. What we suggest is that you always pick more than one agent. So in this instance, you've picked a primary, and you can pick as many alternates as you want. So Mary would make decisions for you, and then if something happened to Mary, then Bob would, and it would go down the line. Why we suggest that you choose more than one agent is because I've had the situation where a lady did the right thing. She wrote a personal directive, told us what her healthcare wishes were and values were, chose her adult daughter, great choice, but unfortunately her daughter died before she did. So then she was left without an agent. So you always want to make sure that you pick more than one agent. So the next part, if you're looking at the template that's got specific healthcare wishes on it, it says optional next to it. And I always wish they would change that and say, this is not optional, you need to write this. Because this is the part that you tell us what's important to you. This is the part where it lets us know what kind of things you're thinking about. What does quality of life mean to you? What does no quality of life mean to you? And would there any be situations where you would not want your life prolonged? For myself, I have in my personal directive that, if I can't recognize my family over a period of time and it's not reversible, then do not prolong my life, right? So that gives my family an idea what's important to me. For some people, it may be prolong my life as long as possible, even if it causes distress, because that's what I would want. You can be more specific. If you have a diagnosis of cancer or kidney disease, you can say, if I lose capacity, please don't continue my cancer treatments. Or if I lose capacity, please don't continue on with my kidney dialysis. So different things for different people. And my mother's personal directive, she was very clear that she did not want CPR under any situation. So she was very clear about what she wanted. You can also put end of life wishes. We have a lovely video on our website, Conversations Matter, which Deb Cook explains how her mother put in her personal directive what she wanted at end of life, that she wanted to be surrounded by family, that she wanted music. And they were able to do that. And that is so helpful, right? That's a gift to the family. And of course, it's a gift to yourself to make sure that your wishes are followed. The personal directive doesn't become legal until it's signed, dated, and witnessed. So your witness doesn't need to be a lawyer or even a notary. As long as they're over 18, they should initial where you've initialed. They need to watch you sign and date it. and they need to sign, and you need to sign and date the personal directive in front of them and vice versa. So you both need to be there when you're doing it. When I was working in hospitals, I would be called in to witness somebody's personal directive, and unfortunately they already signed it. So, and I would have to have them do it all over again, because that's the legal way in terms of making sure they're there. I do want to talk about medical assistance in dying and organ donation, just because we have lots of questions about, people ask questions, can I put that in my personal directive? I had a nice easy answer before, but now the answer is a little bit more convoluted. So around medical assistance in dying, you have to be competent up till the time they're giving you medication. So you can't put it in your personal directive at this point because you need to be competent. But just recently, they've changed it, saying that if you've been already approved for medical assistance in dying, then if you lose capacity in between the time where you've been approved and when they're going to do the medication, then you can sign a form saying that you will be allowed for the medical assistance in dying to go forward. So it is a little bit different than putting it in your personal directive, because you may not even be applying for medical assistance in dying at this point, and your agent wouldn't be able to make that decision for you in the future. Organ donation is a little bit odd too, because your organs don't belong to you after you die. So that's why it's really important to fill out the applications or in the registry form to let us know that this is what you want, and to talk to your family members. My husband came home from having his license re-registered, and he talked about, oh, I put on there that I want to have my organs donated. So that was really important that I knew that, so that if something happened, I wasn't kind of in the dark about what he wanted. Dying with Dignity on their website have an advanced care planning kit, which is really good. Just remember, this is how you find it. It's under education and then advanced care planning. Lots of good questions, lots of ideas of what to put in your personal directive, but make sure you go to the specific Alberta form, because unfortunately our laws aren't the same across the provinces, and you want to make sure that you're filling out the right form. If you're listening and you're not from Alberta, this site is great because you can look at the kit and then go to your province and fill out the right documentation for your province. The greatest takeaway I can give for you today is that don't wait, that the time will never be just right. So for those people that haven't done their personal directive, maybe take the time out today, or even just start that process. And minimally, I have that conversation with your loved ones, whether it's, your husband or wife, or your children, or your grandchildren, or, your best friend, that somebody knows what your healthcare wishes are. So I've been talking about advanced care planning. That's stuff that everybody can do. Everybody over the age of 18. You don't have to have an illness. You don't have to be elderly. Everybody needs that personal directive, and that's the homework that we can do. So, because remember, in the province of Alberta, if you got into a car accident, you have to think about, without a personal directive, who would be making decisions for you, and would they know what you wanted, right? So it's really important that everybody over the age of 18 do that personal directive. But once we have illness, once we have chronic disease, once we have a chronic illness process happening, we need to know right now whether we do CPR or not, what kind of medical care you want right now. And that is based on the goals of care, which is determined by your physician after a conversation with you. And it's based on your values and your goals. That's why it's so important that people have that discussion and think about those things. The best way for me to explain the goals of care is to actually show you a video, because goals of care are things that we do to you. So we have resuscitative care and medical care and comfort care. If you're used to terms like do not resuscitate or DNR, That's American. We used to have those terms long time ago, and those aren't the terms that we use here in Alberta. So these are terms that are used all across Alberta in all our hospitals and all our long-term care and all our home care. So everybody uses the same terms. So I'm going to show you a video that explains what the goals of care are and actually shows you what they look like. Because it's got scenes in an intensive care unit, it shows what CPR looks like. If those are things that are going to trigger you, this video is about 8 minutes. You can step away for about 8 minutes and then come back. These are all actors that are acting in this video. And in fact, the person that they're doing the CPR to is a very large doll. So if you're queasy and if that'll help you get you through the video, then you can think of that. So I'm going to show the video now, showing what our goals of care actually look like.
Goals of care are designations used by your healthcare providers to describe the general aims of your healthcare and the preferred location of that care. Decisions about goals of care usually arise over time through conversations between you, your family, or loved ones and your healthcare team. The process of thinking about, talking about, and documenting your wishes for healthcare is called advanced care planning. In a medical emergency, your goals of care designation guides your healthcare team to provide timely care that is both medically appropriate and reflects your personal values and wishes. There are 3 general approaches to care or goals of care: resuscitative care, medical care, and comfort care. In resuscitative care, the main goal of care is to prolong life by curing or controlling your health condition. This means that doctors and nurses could use intensive medical and surgical interventions, if these are needed, to keep you alive and could be expected to cure or control your illness. If your heart stops, they may perform cardiopulmonary resuscitation or CPR. You may have seen resuscitation or CPR performed on television or in the movies. The person usually recovers easily, but this doesn't tell the whole story. Resuscitation measures like CPR work best in emergency situations where the heart stops suddenly, but the person is otherwise pretty healthy. It's important to know that CPR normally cannot restart the heart or restore life when the heart has stopped as a result of a severe or terminal illness. In CPR, the doctor or nurse repeatedly pushes on the chest with great force and periodically puts air into the lungs. Electric shocks, called defibrillation, may also be used to restart the heart, and some medicines might also be given. If the patient's heart starts to beat again, most patients require a stay in intensive care and a period of rehabilitation before they are well enough to leave hospital, and some people are left with permanent damage from their heart stopping. Resuscitative care can also include using medications and other treatments that are provided in an intensive care unit or ICU. The ICU is a very specialized unit in a hospital with doctors and nurses who are trained in using special equipment and medications to care for very sick people. An intervention that may be used in the ICU to prolong your life is a ventilating machine. These machines are used if you're unable to breathe on your own. This means putting a tube which is attached to a machine down the throat into the windpipe to push air into your lungs. Because this tube can be quite uncomfortable, people are often given medications to keep them very sleepy or sedated. You cannot eat or talk while on this machine. If you have a potentially curable or treatable condition, ICU care might be needed to help you heal. The hope is that you will return to your previous health, but it is important to understand resuscitative care and procedures used with the aim of prolonging life may or may not achieve that aim of restoring your previous health. In medical care, the goal of care is also to prolong life and to cure or control your health condition, but without the use of resuscitative care and the ICU.
Good morning, Mr. and Mrs. Johnson. How are you this morning?
Medical care can be appropriate if your health condition is such that intensive or resuscitative care such as CPR and a breathing tube are unlikely to work. Or your wishes and values about healthcare may be that you would not be accepting of these intensive medical treatments. For example, if they are unlikely to restore you to a state of health that you would want. In the medical approach to care, your doctors and nurses will provide tests and treatments for any treatable problems that may arise. This approach may include surgery and medical treatments such as blood transfusions, kidney dialysis, feeding tubes, antibiotics, and other medicines or fluids given through your veins. Most of these treatments mean going to the hospital.
Of course. You know how much she loves dance. Okay.
Hi,
So, of
Pat.
course,
Good afternoon.
Some people want to receive only the life-prolonging treatments that can be provided in their home or in the care center where they live, even if this limits what treatments are possible. If your goals include a desire to avoid going to the hospital for treatment, talk to your doctor about what treatments may be available and helpful to you in your home or care center. When your health condition or your values and wishes reflect a goal of maximizing comfort and relieving symptoms, this approach is called comfort care. Your doctors and nurses will give you medicines and other medical treatments to help control uncomfortable symptoms such as pain, trouble breathing, or feeling sick to your stomach. The main goal is not to prolong life, it is to maximize your comfort. Resuscitative treatments are not used. Comfort care does not mean that you receive less care. It means the focus of your medical care is on quality of life and reduction of symptoms. People receiving comfort care are usually treated at home, in hospice, or in a long-term care center. However, sometimes hospitalization may be needed to provide optimum comfort.
You know, he feels a lot weaker when he can't keep anything down.
In the hospital, the approach to care will continue to be focused on providing comfort and relieving symptoms. It's helpful to keep in mind your wishes and to know about your own health condition when you are discussing goals of care. Resuscitative care, medical care, and comfort care can be divided into more specific subcategories called goals of care designations. These subcategories provide your healthcare team with important information to help guide medical decisions about your treatment. Talk to your healthcare team about which goals of care designation best reflects your wishes and health circumstances.
So I don't want you to panic at this point, thinking that you have to memorize all the information, because remember, our Conversations Matter booklet goes through all this information. This information is just so that you're better prepared and that you have an idea of what this information is. And when you're having that discussion with your doctor, you're having a little bit more background and feeling a little bit more ease with the information. So this is the goal of care designation order form. And not everybody needs one, right? It's only done if you pretty well don't need something. My mother had in her personal directive that she did not want to be resuscitated, but that time hadn't come yet. And then when she did tell me that, then I went with her to the doctor to make sure that her goals of care were completed, so that if the EMS people came, they would know that that's what she wanted. Because just having it in a personal directive, we don't know if that's a wish for, down the line or when that applies. So the goals of care always has to be completed by a physician or a nurse practitioner. It's not something that we fill out ourselves. And remember, it's done after a discussion with you. So if you're wondering, do I need a goal of care designation order? So not everyone does. I don't have one because I would still want CPR if something happened. But if I lost capacity, then, you know, my personal directive would be enacted, and then my family would follow my wishes around that. So I'm going to sort of walk you through the goals of care that we talked through in the video. And then I think it'll be a little bit more clearer when you would need a goal of care. So the goals of care, as I said, are designated into 3 categories: resuscitative care, medical care, and comfort care. So resuscitative care encompasses how strongly are we going to resuscitate. So it's not like a DNR order, because that only tells us not to give you CPR. Our goals of care actually have a lot more information, and it lets you know exactly what kind of care should be given. So R1, and here's our example: I've been in a car accident, I'm relatively healthy, and I'm going to get whatever treatment that will make me better. I don't know what the outcome will be, but I want to prolong my life at all costs. So right now we're seeing lots of young people end up in the intensive care unit from COVID. They're getting everything that possibly can be given to them to make sure that they come out of it. And we have, you know, lots of people that are doing all right after ICU. R2 is a little bit different. I know that chest compressions will not work for me, but a breathing machine and intensive care will get me back to my active lifestyle. So R2, we're not doing the chest compressions in terms of CPR, but he would be able to access the breathing machines, and he'd be in ICU to make sure if he needed that sort of extra care. R3 is kind of a funny category because it's for some things that are very specific that we take you to intensive care for. We take you to intensive care to receive certain treatment. So the example we have here is I suffer from AFib. Fibrillation is when your heart rate isn't beating it right, and sometimes you have to go into the intensive care unit to be able to get some medication, or for them to sort of shock you so that your heart goes back into rhythm. Sometimes I need to go into the intensive care unit to get my heart rhythm back on track. I do not want to receive chest compressions or be on a ventilator, as they will not return me back to a state that I value. Sometimes R3 can also be used if people have sometimes respiratory issues, chronic issues. They don't want to have CPR because they know that won't work for them, but they do want to go into an intensive care unit, maybe to treat a pneumonia, to make sure that they're on oxygen, and sometimes just to get the medications that can be only given in the intensive care unit. So medical care, we're dealing into another section. Remember the video? Now we're focusing on control or cure of a condition, but excluding CPR and ICU admission. So we have M1 and M2. So M1, I'm willing to go to the hospital for any appropriate medical and surgical treatments to try to fix the fixables. I like to live as long as possible and maintain my quality of life. No CPR and ICR and the ventilator will not help me, and attempted will not leave me in a state of living that I value. So my mother, when she was at home and being independent, she was M1, and unfortunately she had a stroke. So they took her to the hospital. They did not give her CPR. They did not take her into the ICU, but they did give her lots of fancy medication, and they were tests, and they were able to unblock the blockage that was causing the stroke, and she was able to recover. So lots of things can be done without having to do CPR in ICU. So M2 is the next step for people. I want to be treated where I live and not go to the hospital. I want what medical treatments that are available where I live to try to fix the fixables. When I go to the hospital, I just get worse and they cannot fix me. So my mother, she had some arthritis, and after the stroke was not able to live on her own, and had to go to long-term care. And that's when, with her and myself, decided that she doesn't want to go back into hospital again. It wasn't good for her. She had a delirium. And sometimes at 91, the hospitals aren't the best places for you. So she gets treated where she is in long-term care. Her high blood pressure is still being treated. She has macular degeneration and still goes for treatment for that. She has some arthritis, and they'll do what they can in the home. So whether that's in long-term care or in your own home, it means you want to avoid going to the hospital. But let's say my mother falls and breaks an ankle, let's say, then she would be taken to the hospital because they can't fix that in long-term care. But they're going to know that long-term care is where she wants to be. So they're going to fix her and make sure that they take her back to long-term care as soon as they can. Comfort care is a different section. Now we're focusing on comfort and symptom control and maintenance of function. So we're not curing or controlling illness anymore. So it's a different category. So C1, the focus of my care is to provide comfort and to treat my symptoms using whatever medical treatments that will maximize my quality of life rather than focusing on the length of my life. I may be at this level for months or years. In fact, we have lots of people that are C1 with cancer, but they're being maintained so well that they're actually doing really well and may usually, live for years even being on C1. C1 doesn't mean that you don't get treatments, but the treatments are to treat your symptoms, not to cure you. So sometimes we have people that may have a tumor from their cancer, and maybe it's blocking their breathing. We could at C1 remove that tumor, knowing it's not going to cure the cancer, but maybe it's going to make you breathe easier, that it's going to be a little bit easier and you're not going to be in pain. So whether it's blood transfusions, whether it's surgery, we can do all of those at C1, but it's because we're trying to treat the symptoms, trying to make your quality of life better. And the understanding is we know that we're not curing you. C2 is different. I'm in the final hours or days of life, and all treatments are focused on my comfort and support of my family and friends. This is an indication that I should not be transferred to another facility because we don't want people sort of dying en route. So whether you're in the hospital, and even if you're on the list for hospice, we wouldn't move you because we don't sort of want you to die en route. We want to make sure that we're supporting the family and the patient around that time. So hopefully that's an explanation. Remember, you don't need to memorize this. This is just a start of discussion with your physician. I do want to talk about palliative care because sometimes there's a misconception that you can only get palliative care if you're C1. So if you have a life-limiting illness or a life-threatening illness, you can get palliative care being an R1 or C1 and anything in between, right? Because it's looking at you as a whole person and trying to treat your symptoms and making sure that you're as comfortable as possible. So palliative care, can be done at any time in terms of the goals of care. So I want to talk a little bit about next steps. So you've got the information about goals of care. You're wanting to talk to your doctor because you think maybe, there's some things that you don't want maybe, and you want to make sure that your physician has the information. So we have decision tools on our Conversations Matter website that goes through, should I have CPR? Should I stop kidney dialysis? What kind of things should I stop to not prolong my life if that's something that you're interested in? So that's a great place to start. But you can think about things before you go to your doctors. Like, what would you like to know about your illness and what is likely to be ahead for you? Because remember, to be able to plan, we really have to understand where we are right now. What is the most important thing for you to have a good quality of life? Do you want to travel still? So to make sure that you don't have any procedures that would stop you from doing that. And what are you afraid of about your illness? Because, sometimes we can do things around that, but if we don't know what you're afraid of, it's a little bit hard to be able to solve that. What kind of medical care do you not want? We have lots of people that sometimes they've been in the intensive care unit and they don't want to be there again. So those would be really important things that we would need to know ahead of time. And things that you can ask your doctor is, what's this illness going to look like in a month from now, a year from now? And what kind of treatments will help me live the way I want? And what are these treatments going to do about the quality of my life? And are there any alternatives that I can do? So these are some of the things that you can talk about with your doctor. So I'm just going to ask Nicole to put up the next poll. Hopefully
All
Nicole
right.
is.
Here we go. There we go.
So again, this poll is anonymous, and it lets me know if I've given you some information.
I think most people have voted. It's a couple more trickling in.
So it's great that most of you feel that you're better prepared. Hopefully, if you're not feeling prepared, you'd be able to let us know what kind of information would help you with that. I don't know if you
go ahead and share the results now.
Yeah, that would be great. Okay. So we're going to continue on here. So I'm going to show a video, and these two videos are actually people, these are real people. These videos were done in Calgary that are talking about having that conversation with their families, having conversations with their medical team, and what it meant for them, and what it meant for them in terms of to go through that process. So the first one is Dick, and he's the patient, and then the next one is actually a family member talking. Oops, just hold on. Make sure you've got the best.
Well, I was diagnosed with pulmonary fibrosis in December of 2006, actually. And that was after about 5 months of various testing, the type there's no known cause for, and there's no cure. So it's a terminal disease. And it becomes very stressful when you're dealing with that sort of end-of-life disease. And knowing that there's no cure, it's progressed to the point now where I can do very little work, very little exertion, and I'm wearing oxygen 24 hours a day. Dr. Fell sat down with my wife Moira and I, and we talked about the different levels of care and got a good understanding of, you know, if things progress to the worst, what did I want to see happen? And how did I want the medical team to care for me, and what capacity? And the good thing was that my wife was there, and we were able to discuss it, and she agreed upon it as well. So there come to a time when that decision had to be made. She knew exactly what the decisions were. Advanced care planning is a very difficult thing to do, and you know, over the past number of months, you know, my experience with advanced care planning has improved, and my knowledge has improved considerably. My wife and I have a personal directive that was made several years ago, and I view the personal directive a little differently when it, you know, is done in that context. It's maybe a broader scope document, where this is a living document, and it engages not only, you know, your family members, your medical team, and yourself. And so it's a team effort as we kind of go through this process. And it's, you know, I think it's been a good experience for us, and one that I don't regret at all going through and doing and working through with my wife and family. As I say, it's one of those topics that you can easily procrastinate at and say, well, tomorrow is always a better day to talk about that. I think the advice that I would offer to someone that didn't want to get involved would be, more to think beyond yourself and think about your family and to think about what value something like this provides.
Lorraine was diagnosed with a rare form of cancer about 2.5 years ago. It took a couple of months to actually identify the fact that it was a cancer, and once diagnosed, we found out it was a cancer where the average life expectancy is approximately 6 months, and the cancer progressed quite quickly. The surgery was a success, but unfortunately at that time they found that more tumors had developed, and then she unfortunately passed away about 4 months after that. So I think one of the challenges of cancer care is that there's a lot of different opinions out there around what success looks like moving forward in your life. I think everyone hopes that you will survive, and I think everyone has a story or two about someone who defied the odds and did survive. And so you'll always have people who will be trying to, in some way, often in a very well-meaning way, insert themselves into the dialogue around how you treat or how you approach treatment in dealing with your disease. And I think it can be very challenging. So when it came to decision-making at the end of her life and whether or not she would be able to make decisions, I think we were very naive and very lucky. We had talked in advance about what we wanted to have happen, but I don't think we fully appreciated how rapidly these things can come on and how it can impact the person's ability to actually make decisions. She was probably until the last week of her life, she was very involved in decision making, maybe the last 2 weeks. But again, I think we were fortunate because I know of other situations with other families where something like that happens much more quickly, and people don't appreciate how much more of a struggle that can be once the person is no longer part of the decision-making process. I think the main benefit of having the green sleeve was actually knowing that you could take that with you under any medical circumstance and know that the goals of care designation would be honored by whoever that you were interacting with from a healthcare perspective. The advice I'd give around advanced care planning is it's never too soon to be talking about it. I think even before something happened to us from a medical perspective, we were talking about it philosophically. I think we all like to think that something like this will never happen to us, but the reality is, unfortunately, it sometimes does. And you're so much better off having had those discussions in advance than having to deal with them with all of the combined stress of what is happening with you medically, plus the family consequences and everything that gets piled upon you. So to have had a rational conversation in advance of that, I think was critical to us being able to deal with things in a very timely and the smoothest possible fashion that it could have been dealt with. I think everyone hopes that you survive a cancer diagnosis, and what we learned from our experience is sometimes hope becomes spending the best time you have with your family and friends during the remaining time you have in your life, or spending the best quality time possible with your family and friends in the remaining time you have left. So the idea of reframing hope was one of the most valuable things I took away from the experience.
So that's why it's so important that, we do that personal directive and we have those conversations, because, obviously from the videos, age doesn't really play into it. Anything could happen to any one of us at any point in time. I do want to talk a little bit more about medical assistance in dying and where does it fit, because people ask that after, we went through the personal directive and goals of care. I've sort of talked about it in terms of the personal directive, that how it plays in, but in regards to the goals of care, if you are doing the medical assistance in dying, then you definitely would have to be a C1. You wouldn't be able to be a R1 if you were having medical assistance in dying. And if that was something that you wanted to go through, then they would let you know that and they would talk to you about that. So it's not going to come as a surprise if that's something that you're interested in doing. So we have a great website in Alberta for medical assistance in dying, lots of information on there. So even if you're just curious, you can look on that website and see it. All the information is there that you would need, or you can call 811 and talk to somebody. And we actually have medical assistance in dying navigators that would actually help you with that process or even answer your questions. So we've heard talk about the green sleeve, and all the green sleeve is actually that plastic folder that we give out in hospitals and doctors' offices, and it holds all your advanced care planning documents. It holds a copy of your personal directive. It holds the original GCD order form, which is completed by your physician or a nurse practitioner, and the tracking record, which other healthcare providers can chart on any conversations that they've had with you. So this is actually the first time where the patients actually get the original. So you get the original GCD order form and the tracking record, and that goes in your green sleeve. So if you do have a green sleeve, that means you should be keeping it on or around your fridge when you're at home, but also taking it with you to appointments, to emergency, to make sure that people know what your goal of care is. Unfortunately, even though we're pretty well computerized and we're getting better and better at it, the paper is still the source of truth. And sometimes in the computer system, it can be not changed, but meanwhile, your goal of care. So we're always going to want to refer back to the paper and that green sleeve. We're getting closer and closer to be a fully computerized system, but we're not quite there yet. So some common questions that people ask me, do I have to carry this with me everywhere in terms of that green sleeve? Well, in a sense you do if it's important to you. So if your goal of care doesn't include resuscitation, then if something happened to you and you collapsed, the EMS without that goal of care are going to have to do full resuscitation. So I had a little old lady, she had that goal of care with her in her purse. She made sure her family members had copies of it so that everybody was fully aware of what her goal of care was. We don't have a smaller wallet card. Netcare, which is one of the computer systems, it is kind of in Netcare. The issue is it's not always up to date. The problem with a medical alert bracelet is that it's not a doctor's order. The EMS actually has to see that goal of care order form. That's what they're going to be going by. Capsule of life was brought in by the fire department, and it is actually kind of a static thing. It was where your next of kin and important information would be, and they said to put it in the capsule and then put it in your freezer. Remember, I said to take that green sleeve with you. So it's not the same as a capsule of life. Capsule of life is actually kind of for people that don't have a green sleeve or are an R1, so that you can have information about them. But that green sleeve is actually a living document that goes with you. So to emphasize that, I'm going to show you one more video and then we're almost finished, that tells you all about the green sleeve.
A green sleeve is a plastic pocket, like a medical passport, that holds important advanced care planning documents. It is recognized by all Alberta Health Services healthcare providers, so that in an emergency, medical professionals will have access to your personalized advanced care plan and know your healthcare wishes. You may get a green sleeve from any Alberta Health Services provider, either in hospital or the community. You can ask for one, or your family doctor or nurse may suggest you have one. The green sleeve is your personal property, and you should only have one that contains the most up-to-date documents. The green sleeve holds 3 forms: a copy of your personal directive and 2 Alberta Health Services healthcare forms. A personal directive is a form that you complete. It outlines important healthcare decisions, such as where you might want to live, or what would be most important to you in your life if you weren't able to communicate. Anyone over 18 should have a personal directive. You can complete a personal directive with or without a lawyer, and you can use the blank personal directive form provided in the green sleeve. In the personal directive, you name one or more persons who you trust to make personal and healthcare decisions for you if, in the future, you can't make them for yourself because of illness or injury. The person you choose is called your agent. The Goals of Care designation form is a medical order completed by your doctor or nurse practitioner based on conversations between you and the healthcare team. You do not write on this form. A Goals of Care designation, or GCD as it is referred to, is an actual letter number combination that helps the healthcare team quickly know and interpret your goals of care. Not everyone needs a GCD or Goals of Care designation. However, it is useful for those individuals when it is important to know and act on their unique healthcare wishes. The tracking record accompanies the GCD form as a written record of your advanced care planning discussions. When all three of these forms are put in the green sleeve, this package becomes the one source of truth that reflects your wishes and values for healthcare. At home, place the completed green sleeve on or near the fridge, as this is where health responders are trained to look in a 911 emergency. It is also recommended that you provide a copy of the green sleeve to your designated agent, family, and healthcare provider. It is also a good idea to bring your green sleeve to all health appointments. Remember, the green sleeve is like your medical passport. It holds important legal documents that go with you through the healthcare system. If you don't have a green sleeve, ask your healthcare provider for more information. And if you already have one, keep it current and easy to access in case of an emergency.
So I want to have 3 takeaways before we finish. And of course, I've been telling you, don't wait till the time is just right. Make sure you do that personal directive. And you don't need to be an expert in the goals of care. Remember, it's a conversation that you have with your physician, and it may be more than one conversation. And that green sleeve, consider it like your medical passport. And I always think we're able to take our passports along with us. Nobody ever says, well, that's weird, you're carrying it with you. For my mother, when we went out, when we could go out to the mall, I made sure we had that green sleeve in the back of her wheelchair. Our Conversations Matter website, if you forget everything else, all the information that I've talked about today is on there, including the videos. So if you want to rewatch them or look at them with family, you go on our website, Conversations Matter, and all the things are there. So that's what our website looks like. And if you push the tab Patients and Family, that's where the information is. In fact, you can even order green sleeves and have them mailed directly to your home. I think there's only 4 per household, and that's free of charge. So if your physician doesn't have a green sleeve, but in that green sleeve that they're going to send to you is going to be a blank personal directive. But remember, you don't necessarily need to use that one. And is going to be also the other documents and the booklet Conversations Matter guidebook. So a nice complete little package. This is our Conversations Matter guidebook. Why we like it so much is it goes through the goals of care like I explained them to you today. So if you have one of those goals of care, you can refer back to this guidebook and just sort of refresh your memory of what that means, or maybe have a discussion with your physician. It has a nice checklist at the end. It also is available in 7 languages. So if you have friends or family that English isn't their first language, this is a great resource, and you can download, the specific language that you want and be able to give it to them. So I'm going to stop now to make sure that we have any questions that weren't covered in the presentation.
Great. Thank you, Alexandra. That was very informative and clear and detailed. So thank you again. We have a couple questions, audience questions. So we'll just ask a few of those before we let you go. And I'm just going to pass it over to Samantha, and she's going to get us started with the first question.
So the first question is, do you have any tips on how to start these conversations with family who don't like to talk about death or illness?
Well, in terms of, you don't have to start the conversations talking about death and illness. What you can talk about is what's important to them, what kind of things, and you could say, If something happened, what's really important to you? So that's the start. You can use the TV to start a conversations. We're seeing lots of people in ICU right now. And sometimes that can start the question like, oh my gosh, there's so many people that are lining up in ICU. I'm not sure what I would feel about that. How do you feel about that? There's different ways that you can start it. Or you can start it, you know what? I saw this great video today on the website, and can we look at it as a family? And that sometimes starts the ball going. In our Conversations Matter book, if you look at it, there's also conversation starters in there. So you can have a look at that, or just have them read the booklet. Sometimes you're never going to get people to converse, but maybe they're going to write it down. Maybe that's the way they want to do it. So there's little things that you can do to sort of start that conversation off. Or you can say, you know what, I did the personal directive. This is what's in mine. And that might start a conversation also.
Those are good tips. Thank you. We did have one other question that came in. I think Alexandra answered most of the questions as they came in, but we did have one about when you were talking about resuscitation, and I don't know if you have the stats, but we do have a question about the success rate of CPR. Do you have any information on that, Alexandra?
Yeah, don't quote me. I think the latest stat that I looked at is that it's pretty low in terms of even if you're in hospital, and right there, it's around 25% that will come out of it the same way they came into it, even in hospital. So it's not as high as people think, right? So if you collapse and there's somebody right there to give CPR, then obviously your chances are coming out of it. But even in hospital, the chances of you sort of recovering right after it isn't huge, right? So what you want to ask about CPR is how will you react to it, right? In terms of talk with your doctor about your conditions, and if something happened and if you got CPR, the question is, how will I look if I get CPR after it? So those are the kind of questions, because the stats don't really tell you about how you're going to react.
Right. I think there's another question that just came in, actually. Samantha?
Yeah, so it is, where can people pick up a green sleeve?
So like I said, you can go on our website and they'll mail it straight out to your house. If unfortunately, I can't say all doctors' offices have them. Some have them, some not. So if you're unsure, you can always phone your doctor's office and ask them if they have the green sleeve, and some have them. Or you, like I said, go on the website under green sleeve with patients and families. It's really easy to do. You just click on it and they'll send you up to 4 green sleeves directly to your home. So that's about the easiest way to do it. You know, sometimes if you're ill, you're going to get one when you leave hospital, but I don't want you to get one that way.
Yeah, don't leave it until then. That's right. Yeah. Okay, so I have one last polling question that I'm going to launch. I'm happy to lead this one. Just before we let Alexandra go, we have one last poll. If everyone could take a couple seconds to answer that. Now that you know why you need to have a personal directive, would you be interested in attending a Zoom workshop that would teach you how to write your own personal directive? So while this comes in, I just want to give a shout out and thank our Dying with Dignity Calgary chapter for organizing today's session with Alexandra. They're looking to know whether you would like more information on this. So I'm going to end the poll now and share the results.
And just to let you know, if you think of a question after the fact, I have my email on the screen. I'm perfectly happy with answering people's email. I can't give you advice on your personal situation, but I can give you you may have some questions about that you forgot you wanted to ask, or you'll think about later on. So please take my email down and you can certainly ask a question later on.
That's perfect. Thanks, Alexandra. And again, you can feel free to email the support at Dying with Dignity email, and we can always forward your questions on to Alexandra as well if you reach out to us that way. So I just want to take these last couple seconds to thank you again so much for coming on Advanced Care Planning Day and talking to everybody about what's going on in Alberta and to get their advanced personal directives ready and have those conversations with your loved ones and your family members. And thank you again. This has been recorded, so we will be sending out the link. And stay safe, everyone. And it was great to have you all, and thanks for coming.
And thank you for asking me. It was so perfect for being National Advanced Care Planning Day.
Yeah, it was great. Thanks again, Alexandra. Thanks everyone for coming. Bye-bye.
Bye-bye.